Module 5, Oxytocin, Tachysystole, Fetal Monitoring, and Intrauterine Resuscitation. This is Module 5 of Delivery Room Labor Failures, Oxytocin, Tachysystole, Fetal Monitoring, and Intrauterine Resuscitation. The central question in this lecture is deceptively beautiful. How much uterine work can we ask for, and how do we know whether the fetus is still tolerating that work? That is the intellectual center of oxytocin management. Oxytocin is not merely a drug that makes contractions. It is a way of increasing the mechanical load of labor. When the load is appropriate, it can convert inadequate powers into productive labor. When the load is excessive, it can narrow the interval in which the placenta reoxygenates fetal blood, the fetus clears carbon dioxide, and the fetal heart returns to physiologic baseline. So the bedside question is never only, are the contractions strong enough? It is also, are they too frequent for this fetus, this placenta, this mother, and this moment in labor? That is why fetal monitoring belongs in a course on failed induction and labor arrest. The arrest criteria tell us when more time and more uterine activity are diagnostically fair. The fetal tracing tells us when more time and more uterine activity are no longer physiologically free. Let us begin with the contraction itself. A uterine contraction is not simply pressure. It is a temporary change in perfusion. During a contraction, intrauterine pressure rises. When that pressure exceeds the pressure driving maternal blood into the retroplacental space, maternal flow into that space can fall markedly, or even cease for that interval. Gibb gives a useful physiologic figure here. This can occur when intrauterine pressure exceeds roughly 30 to 45 millimeters of mercury. The exact number at the bedside is less important than the concept. Each contraction is an intermittent stress test of uteroplacental reserve. A healthy fetus with a healthy placenta usually tolerates this beautifully. The contraction comes, perfusion falls. The contraction passes, the intervillous circulation recovers. The fetal heart rate remains stable or shows normal variability and accelerations. Labor has always required this intermittent stress. But the system depends on recovery. If contractions become too frequent, too long, or too poorly separated, the fetus loses the quiet interval in which recovery occurs. If placental reserve is already limited, a contraction pattern that another fetus would tolerate may be enough to reveal hypoxemia. If cord compression is added, the tracing may show variable decelerations. If uteroplacental transfer is the limiting problem, the tracing may show late decelerations. If the interruption is more prolonged or more global, the tracing may show a prolonged deceleration, or bradycardia. This is why contraction counting is not administrative bookkeeping. It is oxygen physiology.
The standard definition is precise. Normal uterine activity is 5 or fewer contractions in 10 minutes, averaged over a 30-minute window. Tachysystole is more than 5 contractions in 10 minutes, also averaged over 30 minutes. And tachysystole should be described by whether fetal heart rate decelerations are present. That last phrase matters. More than 5 contractions in 10 minutes with a Category 1 tracing is not the same clinical object as more than 5 contractions in 10 minutes with recurrent late decelerations and diminishing variability. The contraction count tells you the workload. The fetal tracing tells you whether that workload is being tolerated. The local Pitocin protocol uses a related but slightly more operational language. It calls uterine hyperstimulation more than 5 contractions in 10 minutes, or a contraction lasting 2 minutes or longer, or intervals between contractions shorter than 1 minute, even if the contraction duration is otherwise normal. This is very practical language. It reminds the resident not to look only at frequency. A uterus can be dangerous because contractions are too frequent, because one contraction lasts too long, or because relaxation between contractions is insufficient. Now, place oxytocin into that physiology.
Oxytocin works because the pregnant uterus becomes increasingly responsive to it. Oxytocin receptors increase during pregnancy, with maximal concentration in the fundus and less in the lower uterine segment and cervix.
Receptor activation leads to intracellular calcium release and calcium entry from outside the cell. And calcium is the immediate language of myometrial contraction. The fundus contracts, the intrauterine pressure rises. The cervix may dilate. If the cervix is ready, the presenting part is applied well, and the passenger and passage permit progress. Notice the elegance and the danger. The same pharmacologic mechanism that gives us progress also increases fetal workload. Oxytocin is not dangerous because it is artificial. It is dangerous when the induced pattern stops resembling physiologic intermittent stress and becomes inadequate recovery. This is why oxytocin must be managed as a monitored infusion, not as a background medication. Locally, it must run through a pump. It must not be given by IV push, because rapid administration can cause palpitations, hypotension, ECG changes, chest pain, and cardiovascular instability. The protocol expects uterine response within 3 to 5 minutes after starting IV oxytocin, but it also states that steady state is reached around 40 minutes after starting or after a dose adjustment. That distinction is important. The uterus may begin to respond quickly, but the full effect of a dose change may not be visible immediately. A resident who escalates before respecting pharmacologic time can stack effect upon effect.
The local dose ladder also encodes risk. In a nulliparous patient, the protocol begins at 5 milliunits per minute, increasing by 5 milliunits per minute every 15 minutes, with a maximum of 40. In a patient in her 2nd through 5th labor, it begins at 2 milliunits per minute, increasing by 2 every 15 minutes, with a maximum of 30. In grand multiparity, meaning 6th labor or above, or after a previous cesarean, it begins at 1 milliunit per minute, increases by 1 every 30 minutes, and the maximum is 20. Those are not arbitrary numbers. They express 3 judgments. First, uterine response is individual. Second, parity changes the expected sensitivity and risk balance. Third, a scarred uterus and a grand multiparous uterus deserve a slower, more cautious escalation. The protocol also requires continuous fetal heart rate monitoring during oxytocin and continuous midwife supervision, with presence for 10 minutes after initiation and 5 minutes after each dose increase. That is not ceremony. It is recognition that the drug is changing the stress placed on the fetus and the uterus in real time. Now we move from uterine workload to fetal monitoring. Electronic fetal monitoring has a strange reputation because it is both powerful and weak. It is weak if you ask it to predict cerebral palsy. It is powerful if you ask it a more physiologic question. Is there evidence, right now, that fetal oxygenation is adequate or interrupted?
Gabby is very helpful here. Fetal oxygenation is a pathway. Oxygen moves from the environment through the maternal lungs, maternal heart, maternal vasculature, uterus, placenta, umbilical cord, fetal circulation, and fetal tissues. Interruption anywhere along that pathway can appear on the fetal heart rate tracing. A variable deceleration often suggests cord compression because it is abrupt. A late deceleration traditionally suggests uteroplacental insufficiency because it is gradual and delayed relative to the contraction. A prolonged deceleration can come from many points in the pathway: maternal hypotension, cord prolapse, tachysystole, abruption, uterine rupture, rapid descent, or another acute event. The beauty of this model is that it prevents foolish certainty. The shape of the deceleration gives you a clue. It does not excuse you from thinking. A variable deceleration does not prove that the only problem is cord compression. A late deceleration does not prove that the only problem is the placenta. The tracing tells you that the oxygen pathway has been interrupted, and the clinical scene tells you where to search. The same tracing also tells you something about reserve.
Moderate variability and accelerations are among the most reassuring signs in intrapartum medicine. They are not decorative features of the tracing. They reflect an intact, responsive fetal nervous system and cardiovascular control. ACOG emphasizes that in Category 2 patterns, the presence of fetal heart rate accelerations, whether spontaneous or elicited, or moderate variability, or both,
is highly predictive of normal fetal acid-base status. Gabe makes the same point even more sharply. Moderate variability, or accelerations, reliably exclude fetal hypoxic injury at the time they are observed, while their absence does not automatically prove injury. That asymmetry is essential. Presence of reserve is powerful reassurance. Absence of reserve is not a diagnosis by itself. It is a reason to look harder, correct reversible causes, and reassess. This is the difference between mature fetal monitoring and pattern superstition. The basic categories are useful if we use them properly. Category 1 is normal. It includes a baseline of 110 to 160 beats per minute, moderate variability, no late or variable decelerations, and accelerations may be present or absent. Category 1 is not associated with fetal acidemia at the time observed, and it can be managed routinely with evaluation at intervals appropriate to the stage and risk.
Category 3 is abnormal. It includes absent variability with recurrent late decelerations, absent variability with recurrent variable decelerations, absent variability with bradycardia, or a sinusoidal pattern. Category 3 conveys increased risk of fetal acidemia at the time observed. If it does not resolve with appropriate corrective measures, delivery is usually required as expeditiously as feasible. Category 2 is everything between those poles. It is common, it is heterogeneous, it is the category that exposes the quality of the clinician. It should not be ignored because it is not Category 3. It should not be converted automatically into cesarean because it is not Category 1. It requires evaluation, continued surveillance, corrective measures when indicated, and reassessment. So when you hear Category 2, do not hear indecision. Hear an instruction. Interpret. Interpret the baseline. Interpret variability. Look for accelerations. Separate intermittent from recurrent decelerations. Ask whether the decelerations are variable, late, prolonged, or mixed. Ask what the uterus is doing. Ask whether oxytocin, prostaglandins, tachysystole, maternal hypotension after epidural, fever, bleeding, meconium, maternal hypoxia, or a scarred uterus changes the meaning. Ask where you are in labor, latent induction, active phase, complete dilation with a low head, or remote from delivery. Then correct what can be corrected and reassess the response. Let us take decelerations one by one.
Intermittent variable decelerations are common in labor and often do not require treatment. Recurrent variable decelerations are different. ACOG defines recurrent as occurring with at least half of contractions. They require attention to frequency, depth, duration, uterine activity, and the rest of the tracing. If recurrent variables deepen, lengthen, lose shoulders, recover slowly, or occur with worsening variability, they begin to speak a more serious language. But if moderate variability or accelerations remain present, the fetus is unlikely to be currently acidemic. The mechanism is cord compression until proven otherwise, but again, do not become narrow. Cord compression first stimulates baroreceptor responses. If the pattern becomes complicated, prolonged, or accompanied by loss of reserve, then hypoxemia has entered the picture. Management begins with maternal repositioning because position may relieve cord compression. Amnioinfusion may reduce recurrent variable decelerations and may reduce cesarean for suspected fetal distress, although it is not a cure for every adverse outcome. Late decelerations deserve a different physiology. A late deceleration is gradual. The nadir occurs after the peak of the contraction, and recovery is delayed. It reflects a mismatch between contraction stress and uteroplacental oxygen transfer. The causes include maternal hypotension, uterine tachysystole, maternal hypoxia, placental disease, and other limits in the oxygen pathway. Management, therefore, aims to improve uteroplacental perfusion, lateral positioning, IV fluid bolus when appropriate, correction of hypotension, evaluation for tachysystole, and reduction of uterine activity. But even late decelerations must be interpreted with reserve.
A Category 2 tracing with recurrent late decelerations and moderate variability is not the same as recurrent late decelerations with minimal variability and absent accelerations. The first tells you there is intermittent interruption with evidence of current compensation. The second tells you that compensation is less visible, and if it persists despite resuscitation, fetal acidemia becomes more plausible.
Prolonged deceleration, or bradycardia, forces a more urgent search. Think maternal hypotension, cord prolapse, tachysystole, placental abruption, uterine rupture, rapid descent, or a technical problem that is actually maternal heart rate. The correct response is not to stare at the tracing. Call help. Examine the patient. Confirm maternal pulse if needed. Stop uterotonics. Reposition. Treat hypotension. Consider tocolysis if uterine activity is excessive. Prepare for delivery if the tracing does not recover or if the cause is irreversible. This brings us to intrauterine resuscitation. The phrase can mislead. We are not resuscitating the fetus directly. We are treating maternal physiology and uterine physiology in order to improve fetal oxygenation. Each maneuver should have a target. Stopping uterotonics targets the uterine component of the oxygen pathway. If oxytocin is running and there are prolonged or recurrent decelerations, the local Pitocin protocol says it must be stopped and the physician notified. If there is uterine hyperstimulation, oxytocin must be reduced or discontinued. If ProPES is present, the local intrauterine resuscitation protocol says it must be removed. This is the most elegant intervention because it addresses the cause when the cause is excessive uterine activity. It gives back recovery time. Maternal lateral positioning targets uteroplacental blood flow and sometimes cord compression. It may relieve aortocaval compression, improve venous return, change uterine perfusion, or move pressure away from the cord. It is simple, fast, and physiologically plausible. Fluid administration targets maternal circulating volume and blood pressure. The local protocol is appropriately careful here. Fluids can improve a hypovolemic state and indirectly improve fetal oxygenation, but evidence for fluids as a universal fetal monitoring treatment is not strong, and high-risk patients with preeclampsia or cardiac disease require judgment. Again, the intervention is not a ritual. It treats a physiology. Anesthesia consultation targets the common post-regional anesthesia problem of hypotension. If the tracing deteriorates after regional anesthesia, poor uteroplacental oxygen delivery may be a blood pressure problem. The local protocol specifically mentions alpha-androgenic treatment, such as ephedrine, 5 to 10 milligrams as a bolus, repeatable every 5 minutes as needed, with the dilution specified, so each milliliter contains 5 milligrams.
Oxygen deserves special care because it is the classic example of a plausible maneuver whose evidence is more complicated than its tradition. Older algorithms and local Pitocin language include oxygen during intrauterine resuscitation. The local intrauterine resuscitation protocol itself gives the deeper teaching. Fetal hemoglobin and fetal physiology allow survival at lower saturation than a newborn. Early studies suggested improvement in fetal monitoring, but the effect of maternal oxygen on neonatal acid-base status is controversial. Some studies show no improvement in fetal pH, and concerns include free radical generation and possible lower pH values. The local conclusion is that oxygen is at the discretion of the physician managing the case. So the sophisticated resident should not think deceleration equals oxygen mask. The resident should ask whether maternal oxygenation is actually the limiting step. If the mother is hypoxemic, oxygen is rational. If the mother is well oxygenated, and the true problem is tachysystole, hypotension, cord compression, or abruption, oxygen alone is a distraction.
Tocolysis targets excessive uterine tone or frequency that persists despite stopping uterotonics. ACOG lists tocolytic medication, for example, terbutaline, when tachysystole with Category 2 or Category 3 features does not resolve with initial measures. The local intrauterine resuscitation protocol discusses smooth muscle relaxation with beta-adrenergic agonists or nitroglycerin, but specifically warns not to use Ventolin or salbutamol because it is not backed by the literature for intrauterine resuscitation. Local nitroglycerin dosing is worth knowing because acute uterine relaxation is a real delivery room event. The common sublingual spray dose is 0.4 milligrams per puff, usually 2 sprays at once. It can be repeated once after 3 minutes, up to 4 sprays in total. An IV option is 50 micrograms, with effect within 30 seconds to 2 minutes, duration up to about 2 minutes, maximum total dose 200 micrograms, and blood pressure measurement before use and at 2, 5, and 10 minutes after use. Amnio infusion targets recurrent variable decelerations by addressing cord compression, especially after membrane rupture with reduced fluid cushioning. It can decrease recurrence of variable decelerations and reduce cesarean for suspected fetal distress, but it is not a magic protection against all neonatal harm, and the Israeli position paper notes that while it may reduce cesarean rate, it does not improve perinatal outcomes. Now, when do we stop correcting and deliver?
For Category 2, the answer depends on response and context. If moderate variability or accelerations remain, if the decelerations improve after stopping oxytocin and repositioning, if labor is progressing and birth is near, continued labor may be reasonable. If variability becomes minimal or absent, accelerations are absent, decelerations persist, and corrective measures fail, the probability of acidemia becomes more serious, and delivery should be evaluated. For Category 3, the posture changes. Category 3 is abnormal. Corrective measures should begin immediately, but preparation for delivery should also begin because the window for correction may be short. If Category 3 persists despite intrauterine resuscitation, prompt delivery is recommended. The timing language must be honest. ACOG states that the acceptable timeframe for delivery in Category 3 has not been established, and that the historic 30-minute decision-to-incision rule lacks scientific support as a universal biologic threshold. Studies have not shown a simple relationship in which delivery after 30 minutes necessarily worsens outcome compared with delivery before 30 minutes. At the same time, once the decision for operative delivery is made because a Category 3 tracing persists, it should be accomplished as expeditiously as feasible.
The local intrauterine resuscitation protocol is more operational. It describes acute decelerations requiring intervention, separates reversible from irreversible causes, and uses a decision to delivery time not exceeding 30 minutes as an important target, while noting German 20-minute language and ACOG and RCOG half-hour recommendations. The reconciliation is this: do not teach 30 minutes as a magic fetal biology threshold, and do not use the absence of a perfect threshold as permission for delay. Move urgently, organize the team, account for maternal safety, and deliver as fast as the clinical situation safely permits. This distinction is not philosophical. It changes conduct. If the problem is reversible tachysystole with oxytocin running, you stop the oxytocin now, reposition now, consider tocolysis if needed, and reassess quickly. If the problem is cord prolapse, placental abruption, or uterine rupture, intrauterine resuscitation is not the destination. It is a bridge while you proceed to delivery.
The Pitocin protocol gives the same lesson in blunt operational language. Suspected uterine rupture means stop oxytocin immediately and call a physician. Concerning signs include fetal heart rate decelerations, sharp abdominal pain, bleeding, disappearance of contractions, or ascent of the presenting part compared with the prior examination. If the patient transfers to the operating room, the oxytocin bag is disconnected and discarded. She is not transported with an oxytocin bag connected. That rule is not bureaucratic. It prevents an unobserved or uncontrolled uterotonic exposure during the very moment when uterine safety is in question. Let us integrate this into a bedside sequence. A patient is being augmented for active phase protraction. Oxytocin is running. The tracing was Category 1. Now the monitor shows 6 contractions in 10 minutes, recurrent late decelerations, and moderate variability. The immature response is to say either variability is moderate, so continue, or late decelerations, so cesarean. Both responses are too crude.
The mature response is to see the physiology. The uterus is working too frequently. The fetus still shows reserve, but the contraction pattern is interrupting oxygen transfer repeatedly. Reduce or stop oxytocin according to the clinical situation, reposition, assess blood pressure and maternal oxygenation, consider fluids if appropriate, and reassess. If the pattern improves, you have learned that the fetus needed recovery time. If the pattern worsens toward minimal variability and absent accelerations despite correction, the meaning changes. A second patient is complete and pushing. There are recurrent variable decelerations with quick recovery, moderate variability, and descent from +1 to +2. This is not the same situation. The likely mechanism is intermittent cord compression during descent and pushing. You still watch carefully. You may change position, guide pushing, or pause pushing if the fetus needs recovery. But the clinical context includes proximity to vaginal birth and visible reserve. A third patient has a prolonged deceleration after epidural placement. Maternal BP is low. The uterus is not tachysystolic. The treatment is not primarily a cesarean decision at second 1. It is a perfusion problem until proven otherwise. Call anesthesia, reposition, treat hypotension, and prepare for delivery if the tracing does not recover. A fourth patient has sudden bradycardia, vaginal bleeding, severe abdominal pain, and loss of station in a TOLAC. This is different. The physiology suggests uterine rupture. Stop oxytocin if running, call the team, and move to emergency delivery. Here, resuscitation is not a prolonged diagnostic exercise. This is the level of specificity fetal monitoring deserves. Before we close, remember the limitations of the monitor. Electronic fetal monitoring is an excellent negative screen. A normal tracing almost excludes current hypoxic injury, but it is a poor positive predictor of long-term neurologic injury. GABA emphasizes the false positive rate for predicting cerebral palsy is above 99%, with abnormal EFM predicting cerebral palsy correctly only about 1 time in 500. That does not make the monitor useless. It tells you what the monitor is for. It is not a crystal ball for cerebral palsy. It is a live surveillance tool for interruption of fetal oxygenation. Used well, it keeps you from ignoring developing hypoxia. Used poorly, it can drive unnecessary operative delivery. So the final synthesis is this. Oxytocin asks the uterus for more work. Tachysystole tells you that the work may be crowding out recovery. Decelerations tell you that the oxygen pathway is being interrupted. Variability and accelerations tell you whether fetal reserve is still visible. Intrauterine resuscitation is the disciplined attempt to restore the pathway. Stop uterotonics, improve maternal position and perfusion, relieve cord compression, reduce uterine activity, and correct what is reversible. If the fetus recovers, you have not merely bought time, you have restored physiology. If the fetus does not recover, time itself becomes exposure and delivery becomes the treatment. That is the art of this lecture. Do not worship contractions. Do not fear every tracing. Read the uterus and the fetal heart together. The safest labor is not the labor with the most contractions. It is the labor with enough power for progress and enough recovery for oxygenation.